Hello, I'm Aaron Miller, the Medical Director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis at the Icahn School of Medicine in New York, New York. In this podcast, I'll be discussing how to individualize treatment based on new, as well as, of course, old clinical data. Our learning objective is going to be to integrate individualized strategies for treatment selection and for switching based on the latest clinical evidence. So let's start with a case. This is a 32-year-old woman who in November 2017 developed numbness on one toe of the right leg, which spread up to the hips bilaterally over 7 to 10 days. She had no loss of sensation, but the patient did notice heightened sensitivity when she was stuck with a broken applicator stick. Her brain MRI showed multiple periventricular lesions, a juxtacortical lesion, and one gadolinium-enhancing lesion. Her cervical spine MRI also showed one T2 hyperintense lesion. Her symptoms improved nearly completely after a course of high-dose oral steroids. You see the patient about 3 months after the onset of symptoms. At that time, her neurological examination is normal, except that she still reports that sensation feels a little bit different below the knees bilaterally. In terms of her social circumstances, the woman is single, she's not currently in a serious relationship, and she works as a kindergarten teacher. So when one thinks about initiating therapy in a patient, of course, the first thing to know is, does the patient have multiple sclerosis? And what form of multiple sclerosis does she have? And in order to make the diagnosis of MS, we generally apply the Macdonald Criteria. The Macdonald Criteria first came out in 2001, and they have undergone several revisions since then, most recently in 2017. And in order to diagnose a patient with MS, of course, we have to be able to demonstrate that the patient's clinical course demonstrates both dissemination in space and dissemination in time. Now, in the old days, of course, we could use purely clinical criteria to establish those facts, but nowadays it's much more common that we include the use of brain and sometimes spinal cord imaging in order to make that determination. So this patient does meet criteria for dissemination in space, which requires that a person have at least one lesion in at least 2 characteristic locations. Those locations are periventricular, juxtacortical, infratentorial, or spinal cord. And this patient had lesions in the periventricular location, in the spinal cord, and in the juxtacortical location. For dissemination in time, one may establish that by finding new lesions on a subsequent MRI scan, but since the 2010 revision of the Macdonald Criteria, one could meet the criteria for dissemination in time if on the same scan a patient had both gadolinium-enhancing, at least one gadolinium-enhancing lesion, and at least one other T2 hyperintense lesion. So this patient does indeed meet criteria for dissemination in time based on her MRI. With the 2017 criteria, in addition, one could satisfy dissemination in time by finding the presence of oligoclonal bands in the cerebrospinal fluid. So it is indeed appropriate to recommend that this patient initiate disease-modifying therapy. In my view, the decision about a choice of therapy should be made through a process of shared decision-making. And I typically discuss many, if not all, available agents with a particular patient. Then we have a dialogue and hopefully can get to a mutually agreeable decision about a particular drug. I typically now start off my conversation with patients by telling them that we need to decide between 2 strategies for the initiation of therapy. A strategy that we have traditionally employed could be referred to as step escalation. We start a person on a drug that's of relatively modest efficacy, but typically extremely safe. And if the patient shows breakthrough disease to an undesirable level or doesn't tolerate that drug, then we step up the therapy to a drug that may be of higher efficacy, but probably conveys somewhat greater risk. That's the strategy we've most often employed. An alternative strategy might be to start the patient from the get-go on highly efficacious therapy. And we don't know which of these two strategies is better. There are currently 2 trials in the United States that are addressing this, this paradigm difference or this strategy difference. One is known as the Treat MS trial, and the other is known as the Deliver MS trial. And in each of these trials, patients are initially randomized to either the strategy of initial high efficacy therapy, which includes mainly natalizumab and ocrelizumab, but sometimes the off-label anti-B-cell agent or anti-CD20 agent rituximab, and rarely may include alemtuzumab. Or they're randomized to a more moderately effective agent, which includes currently all of the oral and injectable agents. When I see a patient and start to contemplate initiation of therapy, I always bring the patient back for that discussion, which in my hands is quite lengthy. At that first visit, we obtain a number of baseline bloods that will help us inform the decision about therapy. One of those tests that we always do is the JC virus antibody test, which, when positive, is a risk factor for the development of PML, particularly with natalizumab. In this case, the patient's JC virus antibody test was negative. So in my discussion with the patient about these various drugs, we acknowledge the fact of the differences in route and frequency of administration. I go over the efficacy results in the respective trials, and I always emphasize to patients the difficulty of comparing results across trials. Again, telling them that the only way you absolutely know for sure that one drug is better than another is to have studied those drugs in the same trial, which has unfortunately been done relatively infrequently. We also have the difficulty that the more recent agents have been tested against active comparators because of no longer ethical really to conduct prolonged placebo-controlled trials, whereas the older agents were all tested against placebos. In addition to the route and frequency of administration of the agents and the relative efficacy data, we talk about the adverse events, both in terms of tolerability issues and in terms of serious adverse events. So in general, the older injectable drugs in the various interferon preparations and glatiramer acetate had relatively modest efficacy, but they are extremely safe agents. The oral agents in general have intermediate efficacy, but they carry greater safety risks. The intravenous agents, ocrelizumab and natalizumab, which are both available to be used as first-line agents, in contrast to alemtuzumab, which is recommended only for patients failing 2 other therapies in the United States, are regarded as high efficacy agents. Now, as I talk with patients, I'm listening to their concerns, answering their questions, and I'm also watching their body language. I can see the eyebrows go up when I talk about certain risks or certain other issues with particular drugs. Many patients will be very reluctant to use injectable agents, so those come off the table, even though they're very safe. Some patients come to me and say, "Doc, I'm afraid of the side effects of these drugs. I want the absolute safest agent." So those patients, even though the drugs are on average a little bit less effective, might be better off starting on an injectable agent. Another patient may come into the office and say, "Doc, I am really worried about my MS. I'm willing to accept risks, and I want the most effective agent that you have from the get-go." And that patient would be, for that patient, an appropriate choice as a first-line agent might be ocrelizumab, or if they are JC virus antibody negative, as this patient was, might be natalizumab. One also needs to consider their social circumstances. Now, this woman is single and she's not currently in a relationship and probably not planning a pregnancy, but a lot of people with MS, especially since the disease primarily affects women, are going to be in childbearing years and interested in having a family. And that will preclude the use of several of these agents while a patient is actively trying to get pregnant. So all of these considerations go into the conversation. I never believe, or virtually never believe, that there's only one drug that's appropriate for a particular patient. And certainly there's not a single drug that's appropriate for all patients. So it's a complicated discussion. The good news is that the discussion is getting even more complicated as the days go on, because we keep getting more and more effective therapy. Let's move on now to another case. And here we get to an area where, unfortunately, I can't be so enthusiastic about the available options, because this is a patient with progressive disease. So let's say you've been following this 71-year-old woman who has MS for several years. She was originally seen in 2012 at the age of 63 with a history of dragging of her right leg that had been going on for about 8 years and gradually progressing. Her only prior neurological history was an episode of sudden weakness in the right arm that lasted a couple of hours when she was age 52 in 2001. This recovered fully, and she was considered to have had a TIA, and she was told her brain MRI showed lacunar infarcts. She does have a history of hypertension and hypercholesterolemia. Her initial neurological examination in 2012 showed a right hemiparesis, with her weakest muscles being the flexors in her leg, and her gait showed circumduction of the right leg. You've been following the patient regularly since 2012, and she reports little change in her gait. She says, "I have good days and bad days," and she uses her cane on the bad days. Her exam hasn't changed significantly, except for modestly increased weakness of right dorsiflexors of the foot. Her timed 25-foot walk has fluctuated a bit, as they often do, but in August 2012, it averaged 7.7 seconds, and 6 years later, it averaged 8.4 seconds. This may indeed be within experimental error, and certainly it hasn't changed very much. Her brain and cervical spine MRIs show a moderate lesion burden and have been stable. So we're faced with a decision in this patient with progressive MS as to whether or not to initiate therapy. So the first thing we might want to decide is, does in fact this patient have secondary progressive MS or primary progressive MS? So her course has been insidiously progressive, but there was this episode roughly 20 years ago in which she was told that she had a TIA. She was 52 years old at the time. And indeed, that may have been a TIA, and she may have had lacunar infarcts. But sometimes what are called lacunar infarcts on MRIs are, in fact, MST2 hyperintense lesions. And although her symptoms came on suddenly in 2012, if one reads some of the older texts about MS, they say that a not insignificant number of patients with MS present with sudden onset of symptoms. So if we were to assume that that was a lacunar infarct or a TIA, then in fact we would have to say that phenotypically this patient has primary progressive MS. On the other hand, if we think that that might have been not a lacunar infarct, but an MS relapse, then we would have to say that this patient had secondary progressive MS. Now, this illustrates a problem that I find very commonly in my clinic, and that is a difficulty in deciding whether a patient has secondary progressive MS or primary progressive MS. And if one were to go by the prescribing information labeling some of our drugs, that would be an important distinction. Because at the moment, we have only one drug that's approved for primary progressive MS, that's ocrelizumab. And we have no drug approved for insidiously progressing secondary progressive MS without activity. We do have a drug, siponimod, which has been recently approved for patients with secondary progressive MS with activity, which means the relatively recent appearance of new MRI lesions or a clinical relapse. So let's assume for the moment that this patient does in fact have primary progressive MS. Then we would be faced with the decision of whether we ought to recommend that this patient begin treatment with the intravenous infusion drug ocrelizumab. Ocrelizumab had a phase 3 trial known as the Oratorio study, in which there was a statistically significant but relatively modest benefit in the reduction of the number of patients who had confirmed disability progression over 3 or 6 months. So this was of the magnitude of 24–25% reduction. Definitely significant, but not dramatic. On the other hand, it's important to remember that the Oratorio study included patients only 55 years and younger and with a short duration of disease. I believe it was 10 years. This patient has had a long duration of disease and she's elderly. So clearly her likelihood of benefiting from ocrelizumab is probably lower than that for the patients who were enrolled in the ocrelizumab trial, the Oratorio study. And in addition, her risk for adverse events, notably infections, is probably increased by the fact of her age. Her very insidious progression, in fact, it's very difficult even to demonstrate that she is in fact progressing, is rather tenuous. So in my opinion, this would not be a patient that I would recommend initiation of therapy with ocrelizumab. So as you can see, the decision-making process is very complicated when deciding about a disease-modifying therapy. It's becoming increasingly challenging, but also we're getting better and better treatments in general. We still have a lot of progress to make with regard to the treatment for progressive disease. So our SMART goal for this podcast has been to help you integrate data from clinical trials as well as real-world studies for the application in clinical practice. I want to thank you all for joining us and hope that you have found these discussions beneficial.